This is the Fix Your Sciatica podcast.
Let's talk about the pelvic tilt. Oftentimes when you're dealing with sciatica and low back pain, the first thing that clinicians like myself will look at will be your posture. And we'll look at you straight on, we'll look at you from the side, we'll also look at you from the back. What we're trying to identify is any sort of accentuated curves. And one of the most common things that we will often notice is the tilt of your pelvis. But what exactly is that? Is there actually something wrong with the pelvic tilt? And to answer these questions and more, I have Anna Hammond, who is also the co-owner of CES Core Exercise Solutions, and she was really kind enough to share her expertise with us today. So Anna, it's so great to see you, and thank you.
Yeah, thank you so much for having me on the program.
Yeah, I'm really excited because I've been following your company's content for a long period of time. It's actually something that I use to actually help bolster my knowledge in developing core strengthening programs and core integration programs. And I really resonated with what you've been talking about in regards to positioning, but then also pressure. And I was going through your most recent course, your was Postpartum Exercise Specialist 3.0. And there was this entire section about the position of the pelvis. And I really appreciated you saying that there's all these different tilts. It's not really a problem unless it is a problem. And I felt like that was a very important point because practitioners can get so caught up in the positioning where if it isn't a problem, it ends up being extremely distracting and takes away from the ability for people to get stronger and also for their pain to get a lot better. So before we take a deep dive into that, tell us a little bit more about yourself and the journey to where you're at today.
Yeah, I know. There's so much fun stuff to talk about here. Yeah, so I am a physical therapist that had worked in the orthopedic setting for quite some time. And then I ended up having my first child and just kind of felt crooked afterwards. And pregnancy and postpartum information in PT school is very limited. And so I felt like I just needed some more answers to it. So I stumbled upon a very early version of Core Exercise Solutions when it was more focused towards helping the general population versus more professionals, and was like, oh, this makes sense. I vibe with, what she's talking about, where she's looking at things and approaching the body as a whole system, right? Rather than like things in isolation with it. So it then just kind of expanded from there where, Sarah reached out to me and was like, hey, I like your, general vibe and energy and stuff like that. How about you work for me a little bit? And then it just kind of slowly progressed more and more to evolve to, what it is today. And so it's been really fun to use my clinical knowledge and PT knowledge and then my love of learning and educating and interacting with people and being able to go into more of a format that can reach more people and continue to expand upon that where, we're not only providing information for the general population, but also helping other providers in this discussion and exploration and learning so that they can then reach more people. Because in the end, that helps us get even more reach to help more people in the end.
And I love that transition where you were following Sarah's content, who is the original founder of CES, and then you two really vibed in regards to like energy and then also just general content and approach to treatment. And then from there, that's where you have the collaboration. And I think one of the challenges that happens along in healthcare is, one, everyone's in the business of actually helping other people. But I think it ends up being that there's some sort of competition between practitioners. And the reality is the fact that we're all in the same business of helping people. And so the more that we have the opportunity to collaborate, the more opportunities we have to truly help people on a greater scale. So let's talk more about like the meat and potatoes of today, which is going to be pelvic tilting. In general, let's answer the first general question of like, what is a pelvic tilt? Like tell us a little bit more about the pelvis. Tilting also tells us that there needs to be a change in position from relative to something. Tell us a little bit more about that before we go into like the anterior, posterior, and neutral pelvis.
Yeah, for sure. So oftentimes when people are looking at pelvic tilt, they're looking at the orientation or position of the pelvis in the sagittal plane. So thinking like forwards and backwards with it. And so, we want everywhere in our body is meant to move, and so I think that when we're looking at this pelvic tilt and this positioning, it's not just about what it is at rest, but kind of its full available range of motion. And then when you're wanting it to move in that plane of motion. And then like you were saying in the beginning, it's one piece of the puzzle. So I think as we get into the biomechanics lens of things, sometimes it's easy to kind of dive too deep into that and obsess and worry about like every little thing. And then it gives your client some anxiety about like, everything's wrong with me, I'm all broken and stuff like that. And it's like, no. This is just like one thing we're looking at as we build this picture and really a hypothesis of what are potential driving factors to what you're feeling, right? How can we look at movement to determine where too much load is being put onto and then where not enough load is being put through. So I think it's really important to, again, take this all with kind of a grain of salt and think about it within the context of the individual that you're looking at. And then looking at not just statically, but what happens dynamically with movement.
And so in essence, essentially a pelvic tilt is just more so a data point to be able to say, hey, here's this information. Okay, what are we going to do about it? And I'm really glad that you said we take this information, we form a hypothesis, and then from there we be able to figure out, okay, what are the opportunities for us to be able to make changes? I would say that the transition in physical therapy and rehab has transitioned for the better into more of that problem-solving hypothesis lens, where patients are coming in, here's this information that they're presenting to their provider, and then the provider is trying to work these problems out. I remember when I first got out of PT school, it was kind of like, okay, everyone who had back pain or everyone who had sciatica pain would do like the 13 different flexion-based exercises because that's what everyone did. And then I noticed for myself, even as I was graduating, I said, I think there's a better way to treatment. And then over the past 10 to 12 years, I've been starting to really transition more so into that hypothesis problem-solving thinking. And so to be able to look at the pelvis, which, can you give us a little bit more of a quick little anatomy lesson on what the pelvis is and where that's located?
Yeah. So the pelvis is the main bone that's at your hips, right? It's kind of like two wings on each side with it. And so your spine comes down and then forms what's your sacrum, which is a triangle bone in the middle. And then you have your two sides of your pelvis on either side. And then your leg bones attach into that. So your femurs attach into that. And so what we're looking at with the pelvis is, and there's some debate as to like how much movement can actually occur, in particularly like the SI joint, which is where the pelvis and the sacrum join together. It's really, like degrees kind of a thing and can vary per individual, especially like as they get older with it. But a lot of the times thinking about where it can be about intentions of movement versus like, oh, this big grand movement, thinking it's a much smaller joint than say like your elbow, right? So it's obviously not going to move as much. However, there should be some change in tissue length and shortening, right? To help balance out how a muscle moves, how it rests at mid-range, and kind of its movement options available to it. So then when we're looking at the pelvis, today we're going to focus on the pelvis's ability to move forwards in space. So if we think about, we have what's called our ASIS, which are the pointy hip bones in the front side, and then your PSIS, which are kind of the dimples that you'll feel on the back side. So we want to think about if you're holding this pelvis and the ASIS tips forwards and down, and then the PSIS comes up, that's that pelvis going into an anterior pelvic tilt. That is then kind of associated with going into then some lumbar flexion, because as the sacrum kind of tips forward, that's going to encourage more of that lumbar extension. That's going to encourage more of that spine to extend and arch with it. And then if we think about a posterior pelvic tilt, now that ASIS, those front hip bones, are tipping up and back, and that PSIS, the dimples on the backside, are going down and back with it. And that's typically more associated with lumbar flexion or rounding and flattening of that normal lordotic curve. And I think one of the things that people think about is when they're trying to kind of obsess about this pelvis positioning with it, is that one, it shouldn't move in that plane of motion. And it's like, no, we want, by having that full range of motion each way, you're then able to find kind of neutral and again, give kind of all the attaching muscles better movement options to go through. And then Two, they kind of think that like, oh, my spine should be flat, but it's really our curve. We're supposed to have curves throughout our spine. It's like a spring to help with shock absorption. So we do want some of that natural lumbar lordotic curve, and it actually can be an issue if you eliminate that and get it all away.
Yeah, absolutely. 100% agreement with you, which then brings up the question, and this is like a very binary question, which then we can figure out a little bit more why, is this concept of neutral pelvis, right? We have anterior rotation, we have posterior rotation, which means that there is a concept of neutral and being in the center. And I guess in your best answer, is it a good or a bad thing? And from there, actually, no, we'll leave it there. Is it a good or a bad thing? Or is it always a good or a bad?
Yeah. So we want to think about the concept of neutral is that we're in a position where our spine is stable and all the attaching muscles, ligaments, and tendons have minimal tension kind of resting there with it. And then that neutral is kind of determined with, if you think about it in a horizontal plane of the ASIS, so that front pointy hip bone, and the PSIS, the dimples on the back, being level in space. So we want to think about them being level between the two. So you would look at it from the side. Now, other ways that people will kind of assess the position of the pelvis is you can also put the palm, like the heels of your hands, on your ASIS, so on the pointy bones in the front, and then your fingertips on your pubic bone, so down where it comes together in the middle. And then that should kind of be in a vertical plane as far as a neutral pelvis goes. So if you're in an anterior pelvic tilt, the heels of your hands would be more tipped forward and your fingertips would be pulled back. And in a posterior pelvic tilt, it's the opposite of fingertips being forward and then hip bones being more tipped back with it. That all being said, when looking at kind of like the range of normalcy, they say that it's okay, like at rest, people should have 7 to 13 degrees really of an anterior pelvic tilt with it. So I think that, again, instead of being like, here's the robot where we need to have it exactly like this, there's some degree of variability, or again, kind of thinking about, the bigger picture or what happens with dynamic movement with it, right? So if I'm going to say, go into a squat, and ideally when we go into a squat, the backside of your pelvis can open and the front side kind of comes together. So this is moving the pelvis in a different plane of motion with it than this anterior and posterior pelvic tilt. But what can happen is if we have a hard time opening the back of the pelvis, maybe our pelvis tips forward instead, or maybe it tucks under instead. So then you're getting movement from different parts of the body, different joints and different muscles than maybe what your goal was. And then we can think about how you're then kind of, again, driving more movement from, say, the spine and those smaller muscles and areas versus that bigger glute max and that pelvis that has a lot more support and stability with it. So this is where we're talking about that, looking at it at rest is one thing. Then we can look at, okay, what's your ability to go fully into a posterior pelvic tilt, fully into an anterior pelvic tilt, to kind of give a better picture of the movement options in that plane and better help you be able to achieve that neutral position. Then when we're going to do other movements, are you compensating with that forwards and backwards pelvis movement instead of getting the movement from other places instead? The other thing to kind of consider too of, when, again, as we formulate this hypothesis and how much I care, kind of a thing with it, is also asking, about things that people are feeling, right? So, an anterior pelvic tilt is often more associated with impingement, groin strains, hamstring strains, back pain, patellofemoral pain, and it can affect pelvic floor and core function. And then the posterior pelvic tilt, as we'll dive into a little bit more later, is also going to affect how those glutes can function, which can affect pelvic floor function and core function and breathing and bracing strategies.
You bring up two very important principles during that explanation that came to mind. Number one is the fact that our bodies consist of multiple joints. And like if a joint wasn't supposed to move, that joint wouldn't have existed in the first place. So all in all, we do have those like small motions, even though like even as quote unquote stable the pelvis can be. But then the second part is we're looking at this concept of movement and stress capacity. There's only a certain amount of times a joint can move before it starts to get irritated, which also means why it's so important for us to be able to have that stability where, say, for example, if our hips can move, say, 300 cycles, but our backs can only move 100 cycles, but our hips are really stiff, those extra cycles get placed on the back, and that's where we can start to get a little bit of that crankiness. And that's something that I've actually also observed throughout my practice, where transitioning from like, oh my gosh, you should never do X, Y, and Z, it's saying, oh, what isn't moving enough for us to be able to focus specifically on some specific joints. So let's talk a little bit more about the anterior pelvic tilt, because I know that's actually something that I see a lot, especially in the population that I work with, particularly in the folks who are usually, I find that the folks with an anterior pelvic tilt kind of fall into two realms. One, they are just extremely bendy, and as a result, they kind of have to get into this pelvic tilt to create some stability. That's number one. And then the second group are the folks who are actually quite stiff, but they're mostly a lot of like the athletes, a lot of the CrossFitters, a lot of the folks who are just like building up a lot of that like low back strength. And so for the folks who have been told, okay, I have an anterior pelvic tilt, I'm dealing with some sciatica and low back pain, what are some of the big considerations that they should be looking for, their therapist should be looking for, in order for us to say, okay, is this anterior pelvic tilt an actual contributor to my pain? If it is, what are those components that I should be addressing in order to get better?
Yeah, and I think you bring up such a great point of how, our bodies are very adaptable, right? For better or maybe sometimes not better sometimes with it. And so you can think about how you kind of have those two categories of people. So those people that are hypermobile, we can kind of think how they can kind of choose two different paths almost in a sense. They can hang forward and lock out their back joints to kind of support them. They can hang on their hip flexors to kind of support them there. And that would put them in more of that anterior pelvic tilt. If they also are people that like have done a lot of stretching, most likely they've stretched their hamstrings a whole ton, which the hamstrings insert on the backside of the pelvis on those sit bones. So when they're overly lengthened, it actually makes that pelvis fall into that anterior pelvic tilt. They'll say, oh, my hamstrings feel tight, but it's because they're already at end range with it. So it's always interesting when you have someone try to do like a toe touch type thing, and they're like, oh, my hamstrings feel so tight. And then you have them do some concentric shortening work of their hamstrings and then get them to retouch their toes. And they're like, oh, that actually feels better. So it's this counterintuitive kind of feeling with it. And again, where it's about not just the sensation, but looking at movement patterns and range of motion in areas. So then those people on the flip side, if they didn't like being in that position, their body could be like, oh, I need some stability. Let me grip instead. So then maybe they grip their butt and pull themselves into a posterior pelvic tilt. And so it's interesting because again, you can have people where it's like they can go in different directions with it. For the people that have more of that stiffness to them, I find a lot of those people tend to be primarily focused on only strength training in the sagittal plane and only doing bilateral lifts, or even if they're not doing bilateral lifts, they're just doing like a lunge, a squat, a hinge, so everything's just this like forwards and backwards with it. And so again, the pelvis is meant to move. So we need to work on getting rotation behind things, right? Moving side to side, letting a hip come up and come down. So we're kind of loosening all those parts up so we have all those movement options available to us versus just being this robot stuck kind of going forwards and backwards. The other thing I wanted to touch on quickly, and then we'll come back to, how do we work on these things and when is it something to look at, is thinking about, I think that as we get told like, oh, don't do this or this is bad for you, people can fall into this fear of movement, right? And so it's like they stiffen up and protect and move less. So, people will be told like, oh, never round your spine. So they're always in spinal extension, which is then going to keep those paraspinals stiff, which is then going to push them into that anterior pelvic tilt. And then that actually lengthens their abs on the front side. And we need those abs for stability. And so they maybe are trying to do some core work, but they can't because of the resistance against the backside of their pelvis, or again, even if they're to them, because they've done so much work in that extension and forwards, their neutral is still extended, right? Versus actually being in more of that neutral position that we're wanting for that optimal stability and balance of muscles. So for those people, it's like, okay, we actually need to encourage you to do the opposite. We need you to flex that lumbar spine and open it up. And obviously there's times where we need to progress into that. Like if you have a history of a disc herniation, like, going into repetitive spinal flexion can put some strain on those lumbar discs. But as we get later into the stage of healing, we actually need movement in all directions to help that collagen firm up and stiffen up. And again, kind of help with our movement patterns and accessibility to muscles with it. So thinking about anterior pelvic tilt, what does that mean? And I actually just did a post on this on our Instagram. So if you're a visual person, you can go and check out that swipe through that I just did with it. But we can think about, okay, there are a lot of muscles that can pull us into an anterior pelvic tilt. So sometimes you can think about like muscles dictate position or position dictates muscles, and it kind of, goes back and forth in my view with it. But so with being in an anterior pelvic tilt, we can think about how the hip flexors that are on the front can be tight and short. We can think about some adductor muscles, so our inner thigh muscles can pull us into that anterior pelvic tilt. Lats can actually pull us into an anterior pelvic tilt. So up in the shoulders, those big bat wing muscles connect into our thoracolumbar fascia. And when they're short and tight, that pulls us forwards at our pelvis. And so when we're thinking about that stiffness, we're thinking about, okay, yes, we maybe need to do some release work to help get you out of there, to help give you more options to then the muscles that are overly lengthened. The one other muscle to mention too are obviously paraspinal, so the long strappy back muscles we were talking about beforehand too. But then we can think about how we also need to, so in that pelvis being forwards, like I mentioned, the abs are lengthened, those proximal hamstrings are lengthened. So we actually need to shorten those muscles up and work them. So it's this give and take where it's like we need to improve the mobility of the tissues that are stiff, right? And kind of loosen them up and lengthen them. On the flip side, the areas that are overly lengthened, we need to bring some stiffness and tension back to them. So you're restoring the other half of the range of motion that those muscles are missing. Then we can think too, sometimes people will be like, oh yeah, like I stretch my, hip flexors or my adductors and, I feel better, but then it just kind of goes back to like it was. So again, thinking about, okay, the kind of palate cleansing action is a start, but then we have to keep sleuthing to the root of, okay, well, why is it going back to that? So again, kind of getting into some isolated movements or looking at, like I was mentioning, of when you go into your squat or to your hinge, do you actually lengthen through your glutes, or do you arch your back and stick your butt out and lengthen from your abs on the front and hamstrings on the backside?
So through this, where it truly is a discovery of what's at work or what isn't working as much. And you brought up, like, there's two major themes, like from like a muscle action. It's like what is gripping and what is just holding on for dear life, right? And gripping, I perceive that gripping is like things that are in this tightened, shortened position, and then things that are holding on is going to be in the quote unquote tightened, lengthened position. And so it's like, in a simple way, we stretch out the things that are tight, that are truly tight, or we lengthen the things that are truly tight, we strengthen the things that are truly lengthened. And what I say is, like, it's simple, but what's a challenge is, especially if you're going just based off of your own sensation, a muscle that is shortened will feel just as tight as a muscle that is lengthened. And so the way that we can actually determine is something shortened or lengthened is to actually assess how things are moving. So, like, for example, if a person with an anterior pelvic tilt who is actually quite bendy, right, says, oh my gosh, my hamstrings are so tight, and we do say like a toe touch test or like a straight leg raise, and they get up to like 90 degrees, most likely, even though those hamstrings probably feel tight, we've actually surpassed maybe even those norms. So we're thinking, okay, probably that patient is actually in the lengthened position, trying to stretch out those hamstrings. Probably not the greatest idea. So maybe we can focus on, as you said, that concentric focusing, concentric contraction. And then that means, all right, well, if the hamstrings are on the hanging on for your dear life standpoint, let's look at the other end of the spectrum and being able to say, well, what is gripping, right? And through my experience, especially with folks who've been dealing with sciatica and low back pain, who are experiencing that kind of like anterior pelvic tilt position, I notice it presents with a couple specific things. If we look at from the lumbar spine specifically, forced end range back extension can actually shorten up the foramina, which in essence, for folks who are dealing with something like true spinal stenosis, true clinical spinal stenosis, every time they get put into extension, it's going to actually impinge on those nerves. We call it neurogenic claudication, which is why adding that forward bending can actually be important for them. The second part is I also see that it can end up compressing the facets, which can actually end up creating that more of like a pinch sensation. And then, which then translates into the hip and pelvis, which in some cases, maybe the piriformis itself is gripping, which can then actually press on the sciatic nerve itself. So here you have these different areas in which the anterior pelvic tilt, as it's getting influenced, can challenge or produce some of that back pain. So we need to be able to find what is going on to us for us to actually be able to put in those specific interventions, whether it be stretches, exercises, isolated movements. So I'm so glad that you brought that up.
This episode is brought to you by the Sciatica Protocol. Experience pain relief directly through your phone, anytime, anywhere. Interested in learning more? Check us out at ifixyoursciatica.com/the-sciatica-protocol.
Let's go on the other end of the spectrum. Let's talk about the posterior pelvic tilt, right? Like the gripping standpoint. I see this a lot in usually office workers. And then also, just like you said in your courses, I often see this in like a subset of new moms who are kind of like gripping and holding on to everything as well. So tell us a little bit more about the posterior pelvic tilt.
Yeah, for sure. So it is so common in especially newer postpartum moms, but can even continue, past that, because we think about during pregnancy, our abs grow and lengthen, right? So after you have the baby or babies, you're basically kind of a deflated basketball where those abs are still really lengthened. And so you don't, when you were pregnant, you at least had some form of stability a little bit to help stabilize you. And so when you take away the baby from being inside there and putting tension on those abs, now it's kind of like everything wants to just fall backwards. So your body then will add a layer of gripping, whether this is chest gripping, ab gripping, glute gripping, all the grip, to try to hang on for dear life with it. We can also think about how it's common to add gripping to that population and to the population that tends to have more hypermobility. So that population will have more hypermobility because of increased ligament laxity during pregnancy and postpartum with hormones. And so we can add some glute gripping in particular to help with providing stability, right? But then when we add that gripping, this isn't an active squeeze. Sometimes people get fearful where they're like, oh, I squeezed my butt, I'm not supposed to grip my butt. And I'm like, no, that was an intentional movement that you did versus just this low level of clenching that is happening on. And so if, you think about with your jaw, if you're constantly clenching your jaw, it's going to be hard to open your jaw. It's going to be hard to, clench even more, right? So a constantly gripping muscle doesn't move well and dynamically. And I think like you were saying too, is how, you can have that in both that shortened range or you can have that in that lengthened range. And so that's where sometimes doing some release work, just like doing some foam rolling just to kind of help down regulate that system. And I kind of think of it as like taking some dough out of the fridge that you're going to kind of thaw first and let it warm up before you're trying to roll it out and manipulate it and move it. So sometimes we need some of that kind of prep work to be able to then access the muscles more dynamically with movement, with whichever direction you're going to go with it. So, speaking specifically to the posterior pelvic tilt, we can think about how now that pelvis is tucked under. You can think of it as like looking like a dog with a tail between its legs. I also find too, just another population that can go with this, that can be associated with people that have trauma or again, kind of an added layer to the spinal stenosis, like you were talking about. You were saying how like extension doesn't feel great. So what are they going to do? They're gonna be like, well, I'm going to pull myself out of extension. Let me grip and tuck under. And now that foramen is open, but now you've locked other parts up instead. So it's kind of a short-lived strategy that then, opens up another can of worms with things. With that posterior pelvic tilt, we've talked about all that posterior hip musculature is going to be tight and compressed with it. We can also think about how those proximal hamstrings can get involved where it also pulls that pelvis under. And with the hamstrings, it can be interesting too, where people can almost have too much mobility at their knee where their hamstrings insert, but not enough of mobility up top. So what this might look like is someone trying to say, go do a hip hinge, trying to sit back into their hips and open up the back of their pelvis. And they instead shift their knees back fully with them. And so if your knees are shifting back, then you're getting more length from your distal hamstrings than maybe proximal. And it could be a goal. Like if, you want to load more hamstrings in a deadlift of some kind, then yeah, you can have those knees be a little bit straighter. If you want to bias more of the lengthening and load proximally at the pelvis, you're going to keep those knees over that midfoot, kind of create that stiffness at your knee to drive more movement up top. And then just to swing back to then how it would look differently with someone who's more in that anterior pelvic tilt, they might fold over like a paperclip and not get any posterior weight shift and no backside weight shift of opening their glutes, but lengthen all from their hamstrings. So then coming back to thinking about other tight muscles, if we think about it on the front side, we can have our superficial abs of our internal obliques and our rectus that attach to our pubic bone and help pull into a posterior pelvic tilt. Those can actually be tight. So, thinking about the pregnancy and postpartum population, if you have a history of a C-section, a lot of time those adhesions are actually going to pull that pelvis under and then affect the pelvis positioning and your glute function on the backside. So instead, we need to think about like, oh, maybe this is a case where I need to actually breathe into my belly, let myself feel my belly expand. When I'm doing ab work, I'm going to put a towel underneath my lumbar spine to help lengthen those lower abs a little bit, to give them a better place to contract from and work on getting more of a balanced ab engagement. Along those same lines, we can think about how, not all ab muscles are created equal. So sometimes you can have people where they're trying to create stability for their spine and pelvis, and instead of using more of their transverse abs, which are the wraparound corset abs that kind of create this flattening and just kind of like hold in space, they might use more of those superficial abs and always tuck to support their spine and to brace themselves, which then again affects, the resting muscle and position of the other muscles that attach to the pelvis and the spine. Two other muscles to consider. Now we have more lengthened paraspinals. So instead of the shortened paraspinals and the anterior pelvic tilt. So this could be a population where we're actually looking to work their spinal extensors at their lumbar spine to help improve that curvature. And I think a lot of the time we can have muscles that kind of get demonized of like, oh, never feel this or don't use this, kind of a thing, which can have its reasoning behind it. But then there can be other things of being like, no, this is their job. This is what it's supposed to do. When might that person need that? And then the one last muscle to consider is that the psoas. So the psoas is an interesting muscle. So it's a hip flexor muscle, and it inserts on the vertebra, the front of your vertebra, all the way down your spine, starting at L1 and then going down to L5, and then comes forward and wraps around your femur. So L1 through L4, it actually does extension, so arches that back, okay? But at L5, it actually creates some flexion. So I've had people where, again, just like in the hamstrings, you can have kind of these different spots that are sticky and tight and need kind of the opposite actions behind it. So, getting that towel roll kind of at the top of the sacrum at that L5 can help position that part of the psoas into extension and kind of lengthen it there. And then by them focusing on getting their ribs back, breathing into their backside rib cage and getting some flexion into kind of like the higher areas of the lumbar spine, you're releasing the psoas from up top. So sometimes it's that like, instead of just being I'm an extension, that must mean I'm in an anterior pelvic tilt. You kind of have to look at the location of where that extension is occurring with it. And so knowing that natural lordotic curve should be more at kind of L4, L5, and in that postpartum population or in the population where they tend to kind of grip their glutes, they can either have kind of a completely flattened spine, or they can counterbalance where, their lumbar curve is flattened, but then they get more of this extension that occurs at that thoracic lumbar junction at the bottom of their ribs.
Yeah, and I think coming across your Instagram content, I think that area you call it like a higher hinge point or something like that.
Yep, the high hinge point. Yeah, so we talk about basically where you've moved up that lumbar curve to being a little bit higher and have flattened that lower lumbar curve. And again, a lot of time people think about, they're like, oh my gosh, I see that curve, I'm in an anterior pelvic tilt. So they're like posterior pelvic tilting or being afraid of the anterior pelvic tilt. And I'm like, no, you actually need to let your pelvis tip forward. You need to think about lifting those sit bones up, and they feel like it's like blasphemy, kind of going with it. And again, this can be where it gets tricky, where people are like, okay, like lift my pelvis up, and they try to lift their pelvis up and or lift their tailbone up and get that, extension in their spine and length through the underneath side of their pelvis and hamstrings with it. And because it's sticky there, they'll just flare more forward with their ribs. So it's almost like, you need to bring this stability and anchoring to their rib cage in their front to kind of push them back up top and then open up from the bottom half to balance them out with it.
Yeah. And so we have the opportunity to be able to say, okay, here's this pelvis position. And listeners, we talked about these two pelvis positions for the past 30 minutes, right? And we're barely just scratching the surface. And the main goal of this is to show you that there are so many nuances to how our pelvis is positioned, and our pelvis is just one piece of the puzzle because our bodies are amazing dynamic machines and organisms. And so here you have we do have some common principles that you would often see with a posterior pelvic tilt, with an anterior pelvic tilt. But rather than just saying, okay, anterior pelvic tilt, you're going to have these 13 different exercises that you need to do because that's going to fix your anterior pelvic tilt. As Anna was saying, we have to figure out, why are these happening in the first place? Are you a gripper? Are you someone who's holding on? Is it going to be your lifestyle? Is it going to be how you've been lifting? And one of the things I really loved about the courses that your company produces is that not only were you showing like these muscles in isolation and these joints in isolation, talk about these isolation exercises, but then you also say, this is how we tie it into everything. And I think that was another big challenge that I found in conventional medicine or conventional rehab, is the fact that like patients would come in being like, I have back pain. Okay, maybe they have a weak core, so we give them some planks, and then they're done with their 12 weeks of visiting, but we never taught them how to properly bend over, how to pick something up off the ground, how to actually lift their child out of the crib without going into these compensatory movements, right? And so it's important for us to be able to look at your body as, well, we know that these muscles are tight, we know these muscles are lengthened, okay, let's go ahead and put in some specific interventions for that. But then we actually have to reintegrate you into your normal daily activities, because these muscles don't just get tight for no reason. These muscles don't get lengthened for no reason. It's often a product of the things that we do on a daily basis. So this is a question that I didn't send over to you, but I think you'll be able to answer pretty easily. But when it comes to, say, an anterior pelvic tilt, and we briefly talked about in regards to like, this is what happens, what are some of those behaviors or like thought processes that people go like think about that puts them into that anterior pelvic tilt? And I'm going to share just one. I find, especially if you look at the like personal training books, or even just like squatting, back squats, for example, it's like, okay, you step underneath the bar, you brace, you have to arch your back and keep your chest up. Well, what ends up happening is that it places you into that anterior pelvic tilt. And I found that, especially in my height of my CrossFit days, working a lot of CrossFit athletes, I'm actually teaching them, okay, you actually don't need to arch as much. And what they'll notice is the fact that once they actually properly brace and contract their abs, reduce that arch, their pain goes down, their strength goes up, and they're actually able to squat deeper, and they're feeling much more comfortable, right? So what are those other behaviors or scenarios in which you see an anterior pelvic tilt?
Yeah, and I think that's so true, like you're saying, where it's kind of like, yes, you can use this strategy and it will work until maybe it doesn't, right? And so we're thinking about, with this concept of looking at balance of movements and muscles and positioning as helping you be efficient, right? And helping to distribute that load equally. So sometimes when you're going to patterns at first, people might have to back off. They're like, oh, well, I can't, like if you tell someone to front squat first, they're going to be like, but I can't lift as much as a back squat, kind of a thing. But it's all about this kind of, well, there's a purpose behind that front squat. Like that back squat's automatically going to bias you into more extension anyway, because if not, you're going to fall over backwards, right? And so thinking about how, again, okay, yeah, that's okay to go into some extension, but then we need to cross train you with some other move, with some of that flexion, with some of that connecting in the front with it. Or, again, a lot of the time I think that people will be cued, open the chest, and maybe their shoulders don't move as well, so they drive it from their spine instead of from their shoulders, right? So this is, again, where you can think about that it's maybe not just about the pelvis, but what's happening up in your shoulders, right? Like I had a client that I was working with, and she's having some hip stuff that she's working on and making progress, but still kind of, feeling like she's struggling a little bit. And then we're like, okay, like let's look at your feet a little bit, because she has some bunions and toes that are going in, and we do a little bit of footwork, and she didn't change anything about her hip programming. And she's like, my hips feel better. I can move better in my hips, and then it's like, we were working on some upper body strengthening and improving that scapular movement and lats and scapular retraction, kind of getting her chest more open or whatever. And again, she's like, I didn't change any of my hip programming, but my hips feel better. You're like, my single leg squats feel better, So sometimes it's like, yes, you need to look at the area that's complaining to you, but also like, as you're kind of going in that path, if it's not getting somewhere, then maybe we need to look, above and below and see where else is kind of, how can we support that area with it? I think as far as like looking at patterns go, one thing, as we talk about this and people start to reflect of being like, what am I? I don't know, needing an identity behind this all. One kind of really simple assessment that can be really enlightening is, set up a recording of yourself. Because again, perception versus reality can be very different, right? And then if you set up and doing like a cat-cow that a lot of people are very familiar with, but go to do it so that as you go to do it, you keep your hips over your knees and your shoulders over your wrists, and start at your pelvis and move one segment at a time. So you're going to take that pelvis to tuck it under. You're going to lift up through that spine all the way. You're going to push those shoulder blades away from each other and see, can you get an equal arch through the entire backside of your body? A lot of time what happens for those that are in more of that anterior pelvic tilt is they kind of start to tuck their pelvis and then they skip their lumbar spine and then just like excessively move from their thoracic spine. And they're like, oh, I rounded so much. And you're like, except you didn't do it from this area at all. So again, we can kind of look at like, oh, then we need to restore more movement in that direction, in that area, right? To help make it easier to then access the muscles on the other side with it. So you can think about how you can do all your core work that you want, but if you have a lot of that spinal stiffness in the opposing segments on the backside, again, it's kind of like internal resistance that you're working against with it, right? So then to look at kind of the posterior pelvic tilt people, or like what they need to do, we think about with that segmental cat-cow, okay, now let's again start at the pelvis, lift those sit bones up, let that pelvis tip forward into that anterior pelvic tilt, let that spine arch all the way through, let those shoulder blades sink back towards each other. And a lot of time these people can have it where, again, they move excessively from that high hinge point area, kind of flare their ribs forward, but their pelvis it gets to like neutral kind of a thing with it. And even like looking at people, like when you tell them to set up in hands and knees, those posterior pelvic tilters will already be tucked to begin with because that's their kind of neutral with it. But so just an aside of like another kind of easier self-assessment tool to look at and be like, this is where I need to encourage more movement to happen from. So then coming back to the anterior pelvic tilt movements, we can think about how, first, like how do you set up your squatting and hinging in life? And so if you're already kind of tipped forward to begin with, those abs are already lengthened and that stack of that rib cage over that pelvis isn't lined up. So you're not going to have as good of a stability to then drive the movement from your pelvis as you want. So we can think about how some of these prep moves can help you get to that neutral more easily. Sometimes just thinking about that subtle lift of pubic bone kind of up toward your nose, like not so much toward your belly button that you overly tuck, but just kind of creating this nice like lengthening and traction with it. And then saying, okay, as I go to hinge and squat, can I maintain that position in my spine? So I'll have people put their hands on their ribs and their hip bones and feel it on either side and say, okay, as you go to squat and hinge, did that space open up or compress with it, right? So if it opens up, that's you arching that back and going into that anterior pelvic tilt. If it tends to, or flaring ribs, if it compresses, you're going into more of that posterior pelvic tilt. You can also have people kind of feel their hands at their hip bone and pubic bone and kind of feel, does that orientation stay the same? And you can get like a whole torso body moving forwards, and that's not an anterior pelvic tilt. It's just more of moving your pelvis over your femurs and your rib cage with it. It's when that pelvis moves separately from your rib cage that it's putting more of that stress and strain and movement on your lumbar spine. So that's thinking about going down into a movement. Then we can think about coming back out, because I think that is often a case that people miss. So people might get this like great, lengthening from their glutes and legs like we're supposed to with it. And then they come up and they extend with their back and drive out of it using those paraspinals or pull their hips forwards versus getting that rooting down through their legs and using their legs to push them back up. So it's kind of like you can do all this lovely, like the prep work to bring, like equal range of motion each way. And then, okay, now we're going to work this in stability and drive the movement from the hips and legs like we want, as we go to lengthen. And then if they come back up and just go back to like overusing their back muscles, then you've kind of defeated the work that you set in there to begin with. So then you're like constantly trying to undo versus looking at all those patterns. And then the one last thing I wanted to say about that is it's like, again, I think sometimes people, it's easy to go with extremes, and people will take it too far where they're like, oh, I'm never supposed to round my back and, get really paranoid about it. And it's, goes back to, again, being like, this spine is meant to move. Okay, let's make sure we move it in each direction with it.
Pain relief and recovery to like learning how to drive. It's like you were sitting there, we know the rules of the road, right? The rules of the road, you have to stay within the lane. Like those are the components, those are the isolation exercises. But ultimately, we have to step into that car and we actually have to start driving. And it's important for us when we're driving to stay within the lane, to slow down when we're going around the corner, to not hit those curbs, right? Because of the fact that you might know all this stuff. You might know how important it is to not drive into the curb. But if you're consistently driving into the curb, your car's going to get beat up, right? And it's the same thing, especially when it comes to doing all these exercises in isolation. Yes, you know the components, but we need to be able to apply it throughout our day, because that is ultimately what's going to get us better. And that's also in a way, and I find outside of trauma, actually outside of actual like physical trauma, the majority of the injuries and dysfunctions that we develop are kind of, I hate to say it, in a way like self-imposed, because it's like the things that we do on a daily basis, either due to like, and how we do them, either based on like a societal cultural aspect or based on how we were taught. But then also the third part is, especially in pregnancy and parenthood, it's like how our bodies changed over a span of time, of how our bodies end up being adapted. And obviously in the pregnancy and postpartum realm, it's like the body goes through so many significant changes within it's like a long period of time, but also in a very, very short period of time, right? And so it's like, okay, 9 months of developing, like 10 months of developing like this big belly, which then alters how you walk. And it's like the reality is that you develop a habit and behavior in like 12 weeks, right? Which means that your walking is quite different for that period of time. And so being able to take all these components and Anna, we're running out of time, so I don't want to take too much more of your time. But what's really great about all this is the fact that you brought up like, here are these components, here are these things we need to look at, and then saying we have to be aware or in tune with what we're experiencing to be able to make these changes. And the more aware that we are, as the people who are experiencing the pain or dysfunction, the better we can communicate it to people like you and me, who can then do our jobs better, so we can actually get the information and then work off of there. So listeners, you can certainly do a lot of this stuff on your own. There's a lot of information that's out there. We have podcasts like this, right? But then there's also professionals and courses like Anna and myself that can actually help you become even more in tune and also help you recover even faster.
Thank you so much for tuning in. We hope you got some help from today's podcast. And for more info, check us out at ifixyoursciatica.com. Have a fantastic and pain-free day. No patient-therapist relationship is formed by listening to this podcast. We are not providing medical advice, and all information should be confirmed by a medical provider.